Hi, good day. Today we will discuss about vesicovaginal fistula, which is commonly abbreviated as VVF, represents one of the most devastating urogenital complications affecting women. Despite being largely preventable, it continues to impose a significant burden on women's health, particularly in low-resource settings. This presentation will discuss vesicovaginal fistula in detail, covering its definition, epidemiology, etiology, pathophysiology, clinical features, diagnostic approach, and management strategies, outcomes, and preventions with reference to established urology literature. So, what is a vesicovaginal fistula? It is defined as an abnormal epithelialized communication between the urinary bladder and vagina, resulting in the continuous involuntary leakage of urine through the vagina. Unlike stress or urge incontinence, urinary leakage in vesicovaginal fistula is a continuous and unrelated to physical activity or urgency. From a urological standpoint, vesicovaginal fistula represents a failure of anatomical separation between the urinary and genital tracts. The epidemiology of vesicovaginal fistula differs markedly between developed and developing regions. In high-income countries, VVF is relatively rare and most commonly occurs as an iatrogenic complication following pelvic surgery, particularly hysterectomy. In contrast, in low and middle-income countries, VVF remains a major public health problem, primarily due to prolonged obstructed labor. Millions of women worldwide are estimated to be living with untreated fistulas, reflecting disparities in access to timely obstetric care. The causes of vesicovaginal fistula can be broadly categorized into obstetric, iatrogenic, malignant, radiation-induced, and traumatic causes. Obstetric fistulas arise from prolonged obstructed labor, where sustained pressure from the fetal head leads to ischemic necrosis of the bladder and vaginal walls. Secondly, iatrogenic fistulas occur most frequently after gynecologic surgeries, especially abdominal or vaginal hysterectomy. Other causes include pelvic malignancies, radiotherapy causing tissue fibrosis and necrosis, pelvic trauma, and chronic inflammatory or infectious processes. The fundamental pathophysiological mechanism underlying the vesicovaginal fistula is tissue ischemia followed by necrosis. Prolonged compression or surgical injury compromises blood supply to the vesicovaginal septum. Over time, necrotic tissue sloughs off, resulting in a fistulous tract that becomes epithelialized. Once formed, this tract allows continuous passage of urine from the bladder into the vagina, bypassing the normal continence mechanisms. The hallmark clinical feature of vesicovaginal fistula is continuous urinary leakage through the vagina, which usually begins days to weeks after the causative event. Patients often complain of persistent wetness, offensive odor, and recurrent vulvovaginal irritation. Secondary complications include skin excoriation, recurrent urinary tract infections, dyspareunia, that is painful sexual intercourse, and amenorrhea in obstetric cases. The psychosocial consequences such as social isolation, depression, and marital problems are often profound. Physical examination plays a crucial role in diagnosis. Inspection may reveal excoriated perineal skin due to chronic urinary exposure. A speculum examination may show pooling of urine in the vagina or a direct visualization of the fistulous opening. Dye tests such as instillation of methylene blue into the bladder can help to confirm the diagnosis when blue staining appears in the vagina. These bedside tests are simple yet highly informative. Beyond clinical examination, cystoscopy is a key diagnostic tool that allows direct visualization of the fistulous tract, its size, number, and proximity to the ureteric orifices. Imaging studies such as voiding cystourethograms, CT urography, or MRI may be used in complex or recurrent cases to delineate anatomy. Biopsy is indicated when malignancy is suspected, particularly in post radiation or elderly patients. Management of vesicovaginal fistula is guided by several core principles. Active infection and inflammation must be treated prior to definitive repair. Adequate bladder drainage is essential to promote tissue healing. The timing of repair is critical. Most surgeons recommend delaying surgery for several weeks to allow inflammation to subside, except in selected early simple fistulas. Conservative management may be attempted in small, fresh fistulas detected early. Continuous bladder drainage with a Foley catheter can occasionally result in spontaneous closure. Other conservative methods, such as fibrin glue application or electrocoagulation, have been described but show limited success. In the majority of cases, however, conservative treatment is insufficient and surgical repair is required. Surgical repair remains the gold standard for VVF management. The choice of surgical approach, transvaginal, transabdominal, laparoscopic, or robotic surgery, depends on fistula characteristics, surgeon expertise, and patient factors. Transvaginal repair is often preferred due to lower morbidity and high success rates for accessible fistulas. Transabdominal approaches are reserved for high, complex, or recurrent fistulas. Surgical techniques. Several well established techniques are described in urology literature. The Lesko technique involves partial colpocalysis without excision of the fistulous tract through transvaginal route. And secondly, the transabdominal technique, which is known as O-corner technique, performed via an abdominal approach, involves bivalving the bladder for wide exposure and layered closure. Minimally invasive approaches, including laparoscopic and robotic repairs, offer excellent visualization and reduced postoperative morbidity in experienced hands. The postoperative care is critical for successful outcomes. Prolonged bladder drainage, typically for 10 to 21 days, reduces tension on the repair site. Antibiotic prophylaxis and meticulous perineal hygiene are essential. Patients should be counseled to avoid sexual intercourse and heavy physical activity during the healing period to prevent recurrence of fistula. The success rate of VVF repair is highest at the first attempt, emphasizing the importance of meticulous surgical technique. Prognosis is influenced by fistula size, etiology, tissue quality, and prior repair attempts. Radiation induced and recurrent fistulas carry a poorer prognosis due to compromised tissue vascularity. From a public health perspective, vesicovaginal fistula is largely preventable. Improving access to skilled obstetric care, timely cesarean delivery, and emergency obstetric services is crucial. In developing settings, careful surgical technique and intraoperative recognition of bladder injury can prevent iatrogenic fistulas. Education and training remain central to prevention strategies. So, in conclusion, vesicovaginal fistula is a devastating yet preventable condition with significant medical and social consequences. Accurate diagnosis, appropriate timing, and selection of surgical technique are key to successful management. Addressing VVF requires not only surgical expertise but also broader public health interventions to eliminate its root causes. That's it from today's lecture. Hope to see you in upcoming lectures. Take care till that time. Wish you very, very best of luck.